decimation of global health assistance programs, in particular HIV, tuberculosis, malaria, maternal newborn child health, reproductive health, immunization, humanitarian feeding, et cetera, et cetera, et cetera. And since that time, we've grown to thousands of concerned individuals and networks and grassroots directly impacted organizations who are fighting back every day to transform this reality, even as we're describing it. And that's why we're having this press conference. We're now 120 days into a catastrophe that's unprecedented in its scope, in particular because it was the decision of an administration to embrace this devastating and deadly path. So what we'd like to do with the hour and a half that we have together with this distinguished panel of experts from around the world is provide new analysis about what it means that we're now more than 3 months into a decimation of these programs, what communities are demanding to transform this catastrophe, and the role of national governments, as well as the WHO and other global and regional duty bearers to stand up and to fight back. And I think that's the most important reality. Right now, in response to what can only be described as a 5-alarm fire raging out of control, it's disturbing to come to the WHA in the bubble of Geneva and see that the international community is showing up with nothing more than an eyedropper full of water. We can't tolerate business as usual while people are in the crosshairs of preventable infectious disease, preventable health crises, and even preventable suffering and death. Just yesterday, my Secretary of State, Marco Rubio, lied to a prominent committee. The day before that, he lied to a different prominent committee, first in the House, then in the Senate. He said, for example, we won't only talk about HIV today, but I want to give one example before I turn it over to our first speaker from the case of HIV. He told under oath a set of lawmakers that PEPFAR was, quote unquote, 85% functional, and that, quote unquote, 85% of PEPFAR beneficiaries had access to treatment. I tell this story because I need for people to understand that the highest officials in the US government are actually spreading falsehoods. And that's not normal. And we need the WHO, we need UNAIDS, we need all allies, we need national governments around the world to stand up with evidence and with humanity and policy demands to resolve what is a fixable problem. We were astonished that Marco Rubio would tell such lies 3 months into this catastrophe when he has had the opportunity to actually accept that this was an incompetent, disastrous, man-made decision. But he didn't do that. He's doubled down on these misrepresentations. So that's why we're here today, to meet dissembly with fact and the demands of communities in the face of indifference and neglect. So with that, as I mentioned, we have an amazing panel of experts and more comrades in the audience as well. We'll get through rapidly a few presentations and then take your questions. Some of our speakers are in high demand and they need to go elsewhere, so forgive us if there's a little bit of toing and froing. And our first speaker is John Green, who's a renowned author and tuberculosis activist, and he will need to shuffle out a little bit early. So after his remarks, we might pause and see if there's any questions from folks in the audience. Over to you.
Yeah, I'm sorry I have to leave. I wish I could tell you it's because of an important meeting, but in fact it is because I left my passport at the hotel. So that's just Geneva amateur hour right there. I'm very grateful to be with you, and I share Asia's disgust, outrage, horror, and frustration. This is an unprecedented moment in the history of global health. You know, the year I graduated from high school, 1995, 12 million children died under the age of 5. Last year, fewer than 5 million did. That's the greatest accomplishment in human history, the thing that I think I am most proud of as a member of this species. And we are walking back that progress. We are going to see more children die. In the field that I am particularly interested in, tuberculosis, we know that people are dying every day of tuberculosis who would have been on treatment, who would have been diagnosed appropriately, who would have been able to access appropriate treatment, and whose family members would have been able to access preventative care. We know that those people are dying today as a direct result of these aid cuts. And we see this most dramatic. I want to highlight a couple of places where we see this most dramatically. The current best modeling indicates that by 2030, based on these aid cuts, we will see 10 million excess cases of tuberculosis and around 2 million excess deaths. And by excess, I mean more than people who are currently dying. No one should die of tuberculosis in 2025. We've known how to cure this disease since the 1950s. There is absolutely no reason for anyone to die of tuberculosis. The fact that 1.3 million people will this year is a stain upon our societies. But the fact that we're going to see millions of excess deaths over the next 10 years above that 1.3 million is really an indication of where we are at in the world of tuberculosis right now. I want to highlight two places where we're seeing this most dramatically as a direct result of U.S. aid cuts. First, in diagnostics. We are seeing the number of people diagnosed with tuberculosis go down, even as we know the number of people with tuberculosis is stable or going up. We know that it's going up because more tuberculosis is circulating in communities as a direct result of folks not being able to access adequate treatment and preventative care. So we know the amount of people with tuberculosis is not going down, but the number of people we're diagnosing is going down. And we know this is a direct result of U.S. aid cuts because we've seen over and over again that sputum samples aren't getting to where they need to be tested by gene expert tests. We've seen over and over again that tests are sitting in warehouses or in ports. I mean, we talk about government efficiency, but this is the least efficient thing imaginable, to have already paid for tests, to have already paid for treatments that we're not distributing appropriately. So that's one thing I really want to highlight, is the fact that we are already seeing a dramatic decline in diagnosis in some countries, and that should freak all of us out. The second thing I want to highlight is the role of civil society in fighting tuberculosis, which has been completely decimated by these U.S. aid cuts. I'll give you just one example of how we've seen this work. You know, when it comes to drug-resistant tuberculosis, if people have adequate support, if they don't have to go 500 kilometers or 30 kilometers or however far to access their drugs, they are much more likely to complete their treatment. And if they don't complete their treatment, they are much more likely to develop more and more complex cases of drug resistance. We've known this for decades, and yet we are living in a world where hundreds of thousands of people have seen their treatment interrupted, according to the New York Times. We know that means skyrocketing risk of drug resistance for all those people, and we know that making it harder by gutting civil society, making it harder for people to access treatment, leads to lower treatment completion rates, which leads to more complicated cases of drug resistance. That's a catastrophe for individuals. The vast majority of those people will die of tuberculosis as a direct result of decisions made by my government. But it is also a catastrophe for the social order. It's a catastrophe for the social order because it means more complicated cases of drug resistance circulating in communities, threatening us with what we have long feared, that because we have done such a poor job of developing new treatments and new tools to fight tuberculosis, we may live in a world with totally drug-resistant tuberculosis, that we simply have no tools to offer people when they are sick. And that is the world that we are helping to create directly through the decisions made by the U.S. government. And when they say that life-saving aid is flowing, I know exactly what they mean. They mean that lots of people are getting access to their drugs. And that's not necessarily wrong. What's wrong is that lots of people aren't getting access to drugs because they aren't being diagnosed with tuberculosis, and lots of people aren't getting access to drugs because they saw their treatment interrupted, and when they go back on treatment, now they're not being treated appropriately anymore. So you can talk all you want about life-saving services being prioritized, but the truth is that the real life-saving services were already effectively being prioritized. TB has long been underfunded. People have been using extraordinary measures to make sure that a maximum number of people can get access to tuberculosis funding. And to gut that right now in this moment, when we really are at a point of inflection with TB, and we'll hear more about how we're at a point of inflection with HIV, with amazing preventative care coming, but we're at a point of inflection with TB where we're on the edge of having new tools. antiretrovirals. To see that all taken away in an instant has just been catastrophic. And so I want to emphasize 10 million more people are going to get this disease in the next 5 years if these aid cuts continue, and millions more will die of tuberculosis. And we will see for the first time in my lifetime the number of people dying of tuberculosis go up dramatically. Thank you.
Thank you, John. Because your team needs to step out, I wonder if there are any questions from reporters first before you leave, and then we'll hand it over to Serge Yotta from Coalition Plus. Yeah, go ahead.
Hi there. Afternoon. Olivia Lepodova from Reuters. Thank you very much for that short briefing. Just in terms of diagnostics, could you just highlight some countries where you're already seeing that grave impact in terms of reduction of diagnoses happening? Thank you.
Just take the microphone.
In terms of the impact, like I come from Pakistan, right from 21st of January, the vans were grounded, the screening, the ultra-portable X-rays.
Sorry, could you hold the microphone?
The ultra-portable X-rays that we have that were being used for screening, for linking people with the treatment, they have been downed, and ultimately the contracts have been terminated. Pakistan is just one example. We have multiple other countries, be it Kenya, be it South Africa. We have seen services literally vanishing overnight. And it's the multiplier effect in terms of, obviously you're not going to lose your life today, but when you're not going to have access to the treatment and access to the diagnosis in 2 months, you don't know where you'll end. And the number of people you would actually, like when you don't take medicines, you spread bacteria. So the numbers of people who will get into this chain of transmission is way beyond even that.
Yeah, I think it's actually easier to say where we're not seeing it, because we're seeing it in so many places. We're seeing it in Zambia, we're seeing it in South Africa, as Kinz said, we're seeing it in a country that's very close to my heart, Sierra Leone, and not just with TB. I mean, I've been briefing you on TB, but I'll tell you a quick story about HIV. I have a dear friend in Sierra Leone who lives with HIV and who's been struggling to access his medication, and who WhatsApped me and said, you know, what should we do? What can we do? Are these cuts going to last forever? And I said, fancying myself a good accompagnateur, don't worry, we'll make sure that you and your mom can access HIV meds. And he said, thank you, but what about everyone else? And that's the role of government. That's not the role of individual philanthropists. And there's no way that even very wealthy individual philanthropists can come in and make up that difference.
Any other questions? All right, I'm going to pass it over to our next speaker. Thank you, John. Thanks, thank you. To our next speaker, who is the Director of Advocacy with a powerful organization delivering advocacy, community-led research, and capacity development across 50 countries around the world, Coalition Plus. It's Serge Yotta, who will talk about his field experience, and he'll speak in French with consecutive interpretation. Thank you.
Thank you so much, Aja. Et merci à tout le monde. Et merci à vous d'être là.
Serge?
Oui, merci à tout le monde et merci à vous d'être là. En fait, nous sommes dans un moment d'une extrême gravité, parce que ce qui se joue actuellement, c'est quelque chose d'assez inédit. Les dernières estimations de l'ONU-SIDA en matière de ce que pourraient être les conséquences de l'arrêt des financements américains en 2029, c'est 6,6 millions de nouvelles infections, c'est 4,2 millions de décès. Je ne sais pas si on se rend compte de ce que ça représente pour l'humanité. 4,2 millions de décès en 2025 si on ne fait rien. Et
Good afternoon. Thank you all for being here today. We gather here with a sense of urgency to speak out against what is unfolding with every moment of inaction. Actually, what we're witnessing is unprecedented. According to UNAIDS's latest projections, the cost of inaction between 2025 and 2029 will be 6.6 million additional HIV infections and 4.2 million more AIDS-related deaths. Do you have any idea what it means for humanity? 4.2 million AIDS-related deaths in 2025.
J'ai l'impression, en fait, que tout est mis en œuvre, absolument tout est mis en œuvre pour donner la victoire au VIH en 2029. Et si je vais plus loin sur les projections de l'ONU-SIDA pour l'éradication du virus en 2031. L'arrêt du financement en janvier 2025 a eu, et l'effet de contagion que cela a eu auprès d'autres pays, disons, européens, a donné vraiment le coup de sifflet qui a marqué l'arrêt des financements et qui a marqué du coup l'arrêt des activités de prévention. Et cette mise en arrêt a aussi marqué en deuxième étape la mise en suspension, voire la dissolution des services communautaires. Parce que les premières personnes et les premières structures affectées sont les structures communautaires qui font de la délivrance de services de proximité et de première ligne sur le terrain. Et la troisième conséquence, c'est l'isolation. C'est la rupture de services, l'isolation. Bon, les communautés les plus affectées, les usagers de drogue, les travailleurs et travailleuses de sexe, les hommes ayant des rapports sexuels avec les hommes, les femmes trans, mais aussi les jeunes et les jeunes filles, ce sont elles qui sont de plus en plus éloignées du système de santé, du système communautaire, parce que les services qui sont offerts auprès des cliniques communautaires sont celles qui répondent aux besoins spécifiques de ces communautés-là.
I was under the impression that conditions were ripe to reach the UN AIDS goal of ending AIDS in 2031. Yet in January this year, the US announced that they were freezing all their funding, and European countries followed suit. Do you have any idea what came next? First comes the cut in funding, and then the collapse of community services. We know that community organizations are at the front lines of fighting AIDS, and then disconnection from key populations such as drug users, sex workers, children orphaned by AIDS, young people, including young women. They are those who need community clinical services most.
Donc, dans cette étape qui nous amènera vers les 4,2 millions de décès, il y aura, suite à cette isolation et la mise en berne des services communautaires, la réinstallation du virus. On est en train de donner une opportunité au virus du VIH de gagner, de vaincre. Et de vaincre une bataille dans laquelle nous nous sommes engagés il y a déjà 40 ans, avec de fabuleuses avancées technologiques, notamment la PrEP injectable, notamment le traitement ARV injectable. Mais au jour d'aujourd'hui, à cause des coupes, tout cela est mis en berne. Alors nous, à Coalition Plus, lorsqu'on a reçu cette notification de mise en suspens des financements américains, on a voulu comprendre ce que ça voulait concrètement dire au sein des organisations partenaires que constitue Coalition Plus, parce que nous sommes un réseau qui travaillons environ dans une cinquantaine de pays avec un tissu associatif d'environ 111 organisations à base communautaire. Donc nous avons lancé un sondage et 49 organisations ont répondu à ce sondage-là. Et juste 3 semaines après l'arrêt des financements américains, le constat était stupéfiant. Premièrement, 27 organisations de celles qui ont répondu à l'enquête ont signalé une réduction de 55% des services de prévention. 55% des services de prévention ont été arrêtés juste 3 semaines après l'annonce. On a également observé des fins de contrat des personnes qui travaillent au sein de ces organisations-là. 417 personnes ont arrêté de travailler et les pères éducateurs, qui sont les premiers acteurs communautaires qui donnent du service auprès des populations clés, plus de 1000 ont arrêté de travailler et se poser des questions sur comment est-ce qu'on va continuer à délivrer la bonne information au sein de la communauté.
And all this has led to the 4.2 million AIDS-related deaths that I just mentioned. First comes the disconnection from community services, and then the entire system comes to collapse. And then, as we know, HIV is coming back. Yet we were winning this battle that we have started a couple of decades ago. We have made important progress. We have achieved technological advances. Today, we have injectable PrEPs as well as antiretroviral drugs. However, with the funding cut, all these achievements are being compromised. We at Coalition Plus wanted to understand what it means for us. As you know, we are a network of 111 organizations across over 50 countries, and we conducted a survey and over 49 organizations responded. Within 3 weeks of the fund cutting, we realized that the results were alarming. 27 organizations responded to our survey, confirmed that 55% of their prevention work has come to an end. And there were also massive layoffs. A total of 497 workers were laid off. In addition, peer educators who work closely with the population had to discontinue their work. Over 1,000 peer educators said they had no idea how to continue their outreach activities under these circumstances.
Et cela était juste 3 semaines après l'arrêt des financements. Aujourd'hui, nous sommes à 3 mois et pendant cette période, nous avons continué à interroger nos partenaires sur le terrain de l'impact du gel du financement. Et par exemple, notre organisation membre au Burundi, l'ANSS, qui est la première association des personnes séropositives au Burundi, a perdu pratiquement la moitié de son personnel. L'ANSS, ce n'est pas juste c'est pas une association comme n'importe laquelle. C'est une file active de plus d'une dizaine de milliers de personnes séropositives. Ce sont des personnes orphelins du VIH, ce sont des enfants orphelins du VIH. C'est une grosse communauté qui fonctionne sous la base des financements qui viennent de l'extérieur. Et plus encore, en Côte d'Ivoire, nous avons notre partenaire qui s'appelle Espace Confiance, qui délivre des services de réduction de risque auprès des usagers de drogue. Pareil, aujourd'hui, ils ont dû se séparer de presque la moitié de leur personnel. Et pour aller plus loin, pour comprendre un peu les effets de ce financement et l'impact que ça pourrait avoir, avec une organisation partenaire qui s'appelle Data, etc. Et je profite pour remercier Alain Achab, la coordonnatrice, avec qui on a travaillé. On a essayé de comprendre quels sont les flux de financement destinés à la lutte contre le VIH dans les pays. Et pour vous donner une ordre de grandeur, par exemple, au Burundi, le PEPFAR, à lui seul, investissait 66% de la réponse du financement du budget national, du budget de lutte contre le VIH, tandis que le PEPFAR investissait 28% et le budget national était de 6%. Et en Côte d'Ivoire, c'est presque pareil. On a un financement extérieur qui est à 62% avec PEPFAR, 25% avec le Fonds mondial et 13% en financement domestique. Il ne s'agit pas ici pour moi de me lamenter ou de dire ou d'avoir une posture défaitiste, mais juste de présenter des faits. Voici la situation actuelle de comment est-ce que les pays doivent se mobiliser et pourquoi est-ce qu'il est important que tout le monde, que toutes les parties prenantes restent concentrées, restent mobilisées pour en découdre avec la guerre contre le VIH.
And what I just mentioned was the effect of 3 weeks into the halt of funding. And today we're well into 3 months, and our coalition has not stopped measuring impact on the ground. For instance, in Burundi, an organization called ANSS had to let go half of their workers. And ANSS, may I say, is not just any organization. They are an organization working for over tens of thousands of persons with HIV or children orphaned because of HIV. And they rely entirely on external funding. In Côte d'Ivoire, our partner, Espace Confiance, which distributes assistance to drug users, had also had to let go 50% of their workers. And I also want to mention here a partner called Data, etc. I want to thank in particular this organization's coordinators, with whose help we've been able to estimate the real impacts of the funding cut. For instance, in Burundi, the anti-HIV prevention work is funded at 63% by PEPFAR, 28% by Global Fund, and only 6% from national funding. Statistics are similar in Côte d'Ivoire, where PEPFAR used to fund 62% of the entire anti-HIV work. And I'm not here, and let us be clear, I'm not here to seek pity or announce that we've been defeated. I'm just here to present the facts, how these countries will have to mobilize resources now. Let us continue to concentrate our efforts so that we can finally win this war against HIV.
Donc, et pendant ce temps que nous devons rester vraiment très concentrés et très mobilisés pour lutter contre le VIH, les 5 pays qui contribuent au niveau mondial à 90% du financement contre la lutte contre le sida ont décidé cette année-ci d'investir dans la défense. Ils ont également décidé de réduire le budget d'aide publique au développement. Donc pour les États-Unis, c'est acté, je n'y reviendrai pas. Mais pour le Royaume-Uni, par exemple, il y a une prévision d'une réduction de l'aide publique au développement de 40% d'ici 2027. Pour la France, c'est acté, c'est moins 37%. Pour la Belgique, c'est acté, c'est moins 25%. Pourtant, l'aide publique au développement ne constitue pas, en fait, je mets entre guillemets, de la charité. Ça reste quand même un engagement international fort pris par les États les plus riches d'investir 0,7% de leur PIB conformément à la déclaration de Paris. Alors, une fois encore, c'est la présentation des faits. C'est pas, je ne veux pas être très alarmiste, mais ce qui m'inquiète et ce qui m'interroge, c'est que tous ces États ont doublé, voire triplé leur budget de la défense, et d'aucuns ont massivement investi dans l'intelligence artificielle en 2025, ce qui montre que les priorités sont définitivement ailleurs.
And while we continue to concentrate our efforts on combating HIV, 5 countries that used to be the major donors in the combat against HIV, funding, providing over 90%, have now shifted their priorities to national defense. And they've also unanimously decided that they cut their input into official development assistance. We've already discussed the case of the USA. The UK has also decided to reduce their official development assistance by 40% by 2027, France by minus 30%, Belgium by minus 25%. And let us be clear, official development assistance is not an act of charity. It is a commitment made by the richest countries in the world in the Paris Agreement, in which they promised to dedicate 0.7% of their GDP into official development assistance. Once again, I'm just here to state the facts. I don't want to sound any false alarm. And the very same countries that have been cutting budget in official development assistance are tripling or doubling their budget in defense. And in 2025, they're pouring billions in artificial intelligence. Once again, this is a proof that their priorities have shifted.
Et rapidement, pour conclure, je pense qu'il est important, et je profite vraiment de cette opportunité pour attirer une fois de plus l'attention et lancer un appel aux leaders qui sont réunis ici à Genève et qui nous écoutent en ligne, j'espère qu'ils nous écouteront, pour leur dire que la guerre contre le sida n'est pas finie et qu'il y a une opportunité magnifique que nous devons saisir en tant que communauté internationale pour justement venir à côté des pays qui ont le plus besoin. C'est la conférence de reconstitution des subventions du Fonds mondial. On est attendu, la communauté internationale est attendue, et ce qui doit être mobilisé pour le Fonds mondial, pour cette 8e conférence de reconstitution, c'est 18 milliards. Mais nous, à Coalition Plus, nous pensons que 18 milliards reste insuffisant et qu'il en faut 28. Alors, et pour conclure, parce qu'il y a une problématique de temps, je dirais également aux leaders du monde que l'observation que nous faisons en tant que Coalition Plus, c'est que dans ces moments de reprogrammation et de restructuration, on a l'impression et on observe que les communautés sont mises de côté dans les réflexions qui sont en train d'avoir cours. Nous voulons rappeler que les communautés ne sont pas les ennemis de la réponse, ce sont les alliés de la réponse. L'ennemi que nous avons, c'est le virus VIH. Ce n'est pas les communautés qui sont infectées et affectées par elle, et que nous restons disponibles pour collaborer avec l'ensemble des États qui mettent en place actuellement l'élaboration des plans de contingence. Merci.
Last but not least, I would like to seize this opportunity to draw your attention and draw the attention of the leaders across the world who are listening to us right now online, that the war against HIV is far from over, and we have right before us a window of opportunity, which is the Global Fund Replenishment Conference scheduled for later this year. The Global Fund thinks that they need 18 billion, but according to our estimation, according to the estimation of Coalition Plus, we need at least 28 billion to be able to defeat HIV. And I would like to once again call upon the leaders that we, Coalition Plus, are under the impression that during the global reconstruction efforts, communities are being sidelined. Yet we community actors, we community organizations are not the enemy. We are an actor, a stakeholder in the response. Our enemy is the HIV virus, and we Coalition Plus, as well as other community organizations, stand ready to provide our expertise in the making of contingency plans.
Thank you so much, Serge. Our next speaker is building on that point of global solidarity, Mike Podmore from STOPAIDS in the UK.
Thanks, Asia, and thanks, everyone. The announcement of the US cuts in January, as we've heard, were absolutely staggering for all of us. And the whole global community was reeling over the following weeks, dealing with the immediate consequences. We are also sort of trying to assess the longer-term impact, and we've already heard from Asia, John, and Serge just what that's starting to look like. Then on February 25th, after the announcement at the end of January about the US cuts, just 2 days before visiting Trump in the White House, UK Prime Minister Keir Starmer announced a 40% cut to UK development cooperation funding. It was like someone kicking you after you've already been knocked on the floor. This was an even bigger cut to UK aid than the 30% cut that the previous government had made in 2021, and a decision at the time that Prime Minister Keir Starmer was then heavily critical of. The planned cuts mean that in 2027, the UK development cooperation budget will fall to the lowest level in 25 years. And let's be clear, the rationale for the cuts was to take money to increase funding for defence. But this money could have come from anywhere. It is absolutely indefensible that the money will be taken away from the poorest and most marginalised around the world, particularly after the massive US cuts. Recently, International Development Minister Baroness Chapman just gave evidence to the International Development Select Committee in the UK Parliament and said that this cut is not temporary, and that 0.3% of GNI from the UK is the new norm. She gave no trajectory towards increasing to 0.5 or indeed to 0.7, which is in UK legislation. The cuts were set to be implemented by 2027. We thought, okay, maybe at least it can be delayed until then, give time for preparation. But very quickly, it was announced that actually those cuts would be dramatically increased. So while we all here probably, I think, agree that reform is needed in the global development and financing architecture, cuts at this speed and scale are nothing but hugely damaging. These cuts inevitably put an incredible pressure on the scope for critical UK funding needed for HIV and global health. As of 2023, the US, UK, France, Germany and the Netherlands, 5 countries, provide over 90% of global HIV funding. The Burnett Institute estimates that with the planned cuts across these 5 donors, there will be a 24% reduction in total global HIV funding between 2025 and 2026. So I think we're going to hear more about what that's going to lead to in terms of the HIV response, but 6-fold increase in HIV cases, potentially 3-fold increases in HIV cases among children, weakening health systems and increasing rates of antimicrobial resistance. This is the jeopardy we face. It could mean abandoning all the progress that we've made and set us back 5, 10, or even 20 years. But all is not lost yet in the UK. The Minister confirmed that a few areas that the UK will prioritise, and global health is one of those. And this is encouraging. So it gives us hope that we might still see a strong UK commitment to key global health institutions such as Global Fund, UNAIDS and UNITAID. So, but if there are dramatic cuts by the biggest donors to global health, this will have life-altering and life-ending consequences. For example, if there was a 40% cut in the UK's commitment to the Global Fund, this could mean up to 600,000 more people would die as a result. So the UK announced that it is co-hosting the replenishment with South Africa of the Global Fund. And so with that brings great responsibility, both political but also financial. And so we're calling the UK government that it has to, at minimum, meet its last pledge to the Global Fund and to these other key global health institutions. We hope and pray that they will step up and show the leadership that is so drastically needed at this critical time for us all. Thank you very much.
Our next speaker is Kinz-ul-Eman from Dopasi Foundation in Pakistan.
Thank you, Asha, and thank you for the panelists and everyone being here. I come from the implementer and the community side of it. I have seen the experience of the aid being cut overnight, like literally people who are on treatment not being supported anymore, people who were being screened, like we were doing screening with ultraportable X-ray equipped via artificial intelligence in villages across with obviously US support and Government of Canada support. Canada is still continuing, that is still going on. However, 50% of the work that was happening was cut. Just like that. We had no restore but to actually, because there is only a little that a civil society organization or a community organization can actually do on their own. What happened was we had to tell the patients that you actually have to go to the health facility. For drug-resistant TB care, it requires care, it requires acute care that can be done at a specialized site, which are normally 500 or 700 kilometers away from the people. And I have literally seen the pain in the eyes of the patients myself. I had this call on a woman, maybe in her like 60s, walking through a walker, and she was literally like, I just want either you guys to come back or this life to end. I cannot take this pain anymore. It's like, it's literally taking the life out of for the people. Like, you once told them, okay, you have this terrible disease, but we are with you, we'll support you. And now we're just shaking the earth again for them as if just having this terrible disease wasn't enough in the first place. We have made a lot of progress, be it for HIV, TB, malaria. We have got the right equipment. We have a community committed to working. We have civil society committed to working. This is not the time to actually cut. This is the time to actually build on the progress. We are near the finish line, and it's literally that they're just snatching our oxygen supply. So, and for me and for maybe all of us, we don't want other countries to actually use US as an excuse and cut their ODIs. And it's not about money. 1% of the whole economic budget is not money. Don't think about it as charity. We need solidarity at the moment. For me, it's now or never. We are literally at the verge of losing the hard-earned hard-earned stuff. And why it matters to the people sitting here, because we have been in the fight. Now, sitting from the front, like standing with an ultra-portable X-ray in 60 degrees in a city, when you see, like, even after that effort, this day, my community workers are bleeding, my community workers that we were able to actually bring out of that stigma that have done actually told to just leave the belonging and go without any severance. This is not how we wanted the things. This is a breach of trust. This is a betrayal, and this cannot go on. The first thing I learned, last thing I liked, the first thing that I learned personally about global health was disease anywhere is disease everywhere. So if we're not going to do anything, we'll be actually looking for the day when it comes and strikes at our own doors. So we should all do something. We cannot just stand and look at everything happening and losing everything. Thank you.
Thank you, Kinz. Our next speaker is Dr. Matthew Kavanagh, the director of Georgetown University Center for Global Health Policy and Politics.
Thank you all for being here. I want to read a quote to start, which is, "Which ones aren't being funded? I'll fix it right now." So this is what Elon Musk told the Qatar Economic Forum 2 days ago. He said that he was unaware that there were disruptions in programs, but that if there were, he would fix it. So you've heard here very clearly the answer to the question, is it real? Because he said, I don't know of any, I don't think they're real. But if they are, if in fact this is true, which I doubt it is, then we will fix it. As of today, the UNAIDS modeling under the spectrum model shows that we have gone, as the executive director of UNAIDS announced this morning, from 3,500 new infections every day to 5,800 new infections every day. That is what we are seeing at this stage. That is the best modeling that's available right now. That is the situation that shows just how quickly interruptions in services to fast-moving and hugely impactful pandemics can shift. I'm going to give just one example from a country, which is Zambia. So in Zambia, the United States government gives about 600 million total US dollars in all aid, most of which has been disrupted. 367 million of that goes to HIV. And the cuts that have currently happened are having the following effects. 11,000 health workers working on HIV are off the job. 23,000 health workers working on malaria, TB, and other health issues are off the job. 32 clinics serving key populations, LGBT people, sex workers, others, have been shuttered. And in 22 districts, programs serving the HIV prevention needs of young women have been shut down. And so these are some of the examples of what's happening. Right now, we are awaiting with bated breath, in a few weeks, the approval of what is the closest thing to an HIV vaccine that we are likely to have before 2030, which is the drug lenacapavir. The United States Food and Drug Administration is poised to give that approval within weeks. And the plan had been to roll out millions of doses of that new drug in Africa, Asia, and Latin America. This is a drug that in clinical trials showed 0 new infections in one arm of the clinical trials among African women. In other settings, it showed 95, 96, 97% impact in reducing new infections. And it is a shot that is given twice a year, with a new version of it likely to come within a few years that is once a year. That is a game changer when it comes to how you interrupt a pandemic. And yet now, the current plan has been massively disrupted and is very unclear. It's not clear how many doses of lenacapavir will roll out at all. And what we are hearing from the manufacturers who have been prepared to make lenacapavir around the world is that they are not sure that there will now be a market for this drug, and they are not sure how quickly they're going to be able to move. So in this context, I want to just close by reading the text of the pandemic treaty that was just passed. So the ministers of health of the world came together and they said that the goal of the new pandemic treaty is solidarity with all people and countries in a context of health emergencies, as well as inclusivity, transparency, and accountability to achieve the common interest of a more equitable and better prepared world to prevent, respond to, and recover from pandemics. This is the commitment that world leaders came here to Geneva to make. And currently, they have the opportunity to do so. The question is, will they? In a pandemic that is ongoing, is active, and is real. Because make no mistake, AIDS remains a pandemic. Will it ravage the rest of the world in an accelerating pace, or will the world come together to stop it? Thank you.
Thank you. Our final speaker is Peter Maybarduk from Public Citizen, a civil society organization that's worked with NGOs from around the world who are suing the U.S. government for their unlawful impoundment of appropriated funds for life-saving supportive assistance. Over to you, Peter, and then we'll open it up for questions.
Thanks. I was just going to use this mic if I could. Great, because I have some notes. Thanks, everyone, and thank you, Matt, for those words on lenacapavir. I'm going to have to run out right after I speak because we're doing some organizing work in Latin America on that right now to try to bring down the cost. If we don't have the resources, of course, we have to bring down the costs and work both ends of the problem. So in those first terrifying days after Trump's executive order, with Asia organizing all of us and with Matt's help, we all knew that we needed to sue. But many grantees in the United States naturally were afraid of the consequences of standing up to such an administration. And so the first step that had to be taken to start a resistance was to tear down that wall of fear and find someone to take the first step and sue and start launching legal challenges. We were fortunate to find the AIDS Vaccine Advocacy Coalition, and the AVAC stood up, followed by many others. So we sued the Trump administration for its illegal and unconstitutional freezing of foreign aid and shuttering of USAID, which has devastated global health. I'll talk about each case briefly. AVAC versus the Department of State, we won a temporary restraining order on February 13th that prohibited the government from terminating grants under Trump's executive order. The government failed to comply, and this is a pattern that we see again and again. Plaintiffs in the cases had to go to court and go back to court and go back to court to seek enforcement, which the court has ordered. Trump appealed all the way to the Supreme Court, but we prevailed. And this was an important early check on Trump's power, reestablishing basic legal principle that you can't just ignore Congress. But outrageously, and as we all know and have experienced, this did not stop the destruction. The government continued terminating awards at a rapid pace. And now this is a challenge we have across the board. Destruction is fast. The law is deliberate, and this government does not care. They're claiming they conducted individualized reviews. Now, we don't think that's accurate. Some might use stronger language. But that's how they justify keeping cutting and doing what the court already said was illegal. On March 10th, we won a preliminary injunction saying that the government has to pay up for terminations before February 13th when the court's restraining order issued, and saying that the government can't impound congressionally appropriated foreign aid funds. The government has not complied at all with that last element on impounding funds. They've appealed, and oral arguments are scheduled for July 7th. What the court has not yet specifically done for us is block the terminations after February 13th, after the restraining order. We're working on that. Now, we've actually won a lot. We think we have a good chance on impoundment. The timeline is longer than we like, and how to re-obligate the money after so much destruction may not be as straightforward as any of us like. There's a much bigger fight here, of course, that depends on all of us in this room, all the fantastic activists on the stage today and around the world. The second case, American Foreign Service Association versus Trump. challenges the dismantling of USAID on behalf of two unions, one of which my father had been a member of during his career with the Foreign Service, and Oxfam America, which, of course, is facing a massive shortfall because of the closure of the agency. We won a restraining order to reinstate USAID employees, but then lost our motion for a preliminary injunction. We moved for summary judgment. The government moved to dismiss. We say the dismantlement of a federal agency without Congress violates the Constitution and is otherwise unlawful, and we're awaiting the court's decision. Meanwhile, the dismantling continues, and as you know, the administration is now subsuming USAID under state and giving final departure dates for the remaining staff, some of whom we know continue to really work courageously to get grants out and keep the lights on. We'll keep fighting like hell. And of course, we here today all appreciate that we need activism and politics as well as law to fight back. So we're all going to go do more of that now. Thank you all so much for your work. Really glad to be in this fight together.
So we've heard from Kinz, from Serge, from Matthew about how we don't have any time because of the horrific impacts at the community level. And then we've heard from Peter that U.S. courts move slowly. They move too slowly, even when what's happening in front of us is immoral, wasteful, and is patently unlawful. So with that, what questions do people have? And I know there are also other resource people and colleagues from the global health community. If you have any comments to make, feel free. Olivia from Reuters, go for it. Thanks.
So I have to excuse myself with apologies, but Asia's got my email. We have questions about the cases. We'll get them to our litigators. We'll get back to you.
Thanks all. If I may, I'll just start with Lena Kapavir. Excuse my ignorance, I have heard it being spoken about a lot recently, but just on the technical front, in terms of you saying about the rollout plan being disrupted, could you just give some detail on exactly why that is and how that works in practice? That would be really helpful just to kind of help get my head around that. Thank you. And then my second question is, you spoke very compellingly about the impact in terms of staff cuts, immediate impact on community clinics, etc. I just had a question about if at any point so far there are concerns about stock outs yet, or whether that's something which is more maybe the next 3 to 6 months or beyond. And really, thank you very much. And your message is, each and every one of you landed very clearly and compellingly. Thank you.
I can start and then share with others. So just on lenacapavir, the vast majority of PrEP scale-up that we've seen, which is pre-exposure prophylaxis scale-up in recent years, has come through a combination of the Global Fund and PEPFAR. And in fact, U.S. government support has funded the majority of the scale-up that has happened, much in Africa especially. The plan that was announced by the Global Fund and PEPFAR and the Gates Foundation together was to purchase 2 million doses immediately of lenacapavir at the time when there is not a generic that's going to be available, and so to buy it directly from Gilead. The PEPFAR program is a large portion of that 2 million doses. And so now it's unclear whether the Global Fund will have the money to cover some version of that, whether or not the Gates Foundation will step up to do that. And 2 million was an insufficient number to begin with, right? And so the hope was that there would be 2 million coming from the Global Fund and PEPFAR and the Gates Foundation, but that also you'd see other governments stepping up. And so South Africa, for example, was planning on making a purchase of lenacapavir and trying to move forward on that. You see other governments doing the same. All of those are now moving to figure out how they sustain the AIDS response. And so the Global Fund is mobilizing all of its resources to figure out how you first sustain everybody on treatment, and second, try to maintain the programs. And so trying to imagine how you then continue to purchase lenacapavir is challenging. There's still a commitment, there's still intention, there's still a desire to do so, but it's not clear how much is going to be possible. South Africa is now facing a 20% hit to its HIV program. Now, luckily, South Africa pays the majority of its HIV program already, right? So these are costs that are on top of that. But if you're already absorbing somewhere between 17 and 20%, it's not clear how you then make a tender for a big new purchase. And the third that is probably the most disruptive, is that we know that for Africa, Asia, and Latin America, there's no way that a brand name medicine, which is tens of thousands of dollars, is going to be able to be purchased by these governments. And so the solution has always been, and the plan has always been, to make generic versions of it, the estimates of which are that you could make it for probably somewhere between $40 and $100, which means that at that rate, made generically, you could actually afford to roll that out across the world, and it really could be a game changer. We've spoken to several of the manufacturers. There's others in the room, like WHO, who have other knowledge. We are trying as much as possible to keep everybody on the track to be able to do so. But those manufacturers are turning now and saying, is there going to be a market for this? Because this requires that they invest in production lines, that they invest in training, that they invest in doing so. They now have the license and we're planning to do so, but all of a sudden the market is disrupted. If what we see is they pull back for the next 12 months to just see what happens, that means we are going to be years that will be set back before this is generically available. And we do not have years, right? This is the best, this is the closest thing we have to a vaccine. And if we have years before it rolls out, if instead of 3 years, we're talking about 10 years, which is what's happened in the past with new technologies, then we will not see it have the impact that we're going to need. So that's where it's coming from. And just in terms of stockouts, yes, we are definitely seeing stockouts in multiple different places. If you go, the UNAIDS website specifically has a number of different examples. The Global Fund, WHO, the whole UN family has, I know, been mobilized to try to prevent them, right? And is working overtime to make that happen and doing the analysis and trying to get in the way of that. But one of the things that disappeared overnight in some places are the data systems. Because it turns out that the data systems were largely funded in some countries by the PEPFAR program, and when they disappeared, all of a sudden governments are now flying blind, which is deeply, deeply irresponsible. I cannot imagine a more irresponsible thing than to shut off the data programs, data systems for an ongoing pandemic. So I'll leave it there.
Yeah, regarding the scenarios, if I talk from my country and other countries, because I was supporting Stop TB Partnership and the Community Hub to assess the impact on TB programmatic funding. There has been 58% impact when we talk about the advocacy activities. There has been 80% impact when we talk about the community activities and the activities that would be in terms of screening, scaling, etc., etc. That have to be descaled. When it comes to drugs and when it comes to diagnostics, be it the gene expert cartridges or the drugs, Global Fund at the moment has issued. Firstly, it issued slowdown letters, then some operationalization letters, because they're also not sure if they're going to get even the next tranches or not. So at the moment, I'm being told that we have like 6 months of medicine supplies and we have like 4 or 5 months of cartridges supplies. Beyond this, what we're going to do, we don't know. And then for the first time in the history, the Global Fund will be sending deallocation letters to the country because of the shrinking space. So it's like Hunger Games even at country levels. Okay, let's give something to malaria. No, let's give it to HIV. Let's give it to, okay. So they have to decide and slow whether they need to save people with DRTB, whether they need to save people with TB, malaria, or HIV. So it's like, it's a chaos going on, so we cannot really comment on what's going to last, and even if something is there today, whether it will be there tomorrow or not.
Just before we hand it over to the next 3 questions, I want to dramatize what the PrEP capacity was in 2024 that has been canceled because of terminated awards. 2.5 million people lost access to PrEP, it's predicted, in 2024. That's the volume that would be built out from, with injectable lenacapavir. And for those who, coverage should be orders of magnitude beyond that for oral PrEP, the existing standard of care. And it's not. We were already having a crisis of PrEP scale up. With the termination of awards, 3.5 million people who identify as key populations lost their prevention services. These are among the people who are most in need of superior injectable long-acting PrEP. The currently available cabotegravir, which is injectable PrEP that is given more often than twice a year, but is important to exemplify how the cuts are already halting that extremely unambitious rollout program in its tracks. The goal for CAB-LA rollout for 2025 was 100,000 doses only. That's a pittance, but right now it's only 5,000. Fully 230,000 doses of that effective injectable long-acting PrEP are actually trapped in a warehouse in England by the manufacturer Vive. It's the property of the US government, but it's not making its way to the country where it's destined to go, which is South Africa. 230,000 doses, still a drop in the ocean, but stranded because of these decisions. Already paid for and completely stranded. And go to Chai's impact memo, you'll see multiple countries already facing stockouts, and most importantly, stockouts for medicines for advanced HIV disease, that's for treatment and screening for AIDS, and for pediatric treatment, so both conditions for which spikes in mortality are extremely soon when there's not access to treatment, care, and support. Paul, and then Andrew, and then in the front row.
Hi. I wondered, Matt, if you've heard of anything of countries raising money on the international markets to fill the gap locally.
Largely, no. And here's our situation. The most affected countries currently are spending more in debt payments already than they are spending in health each year. And so then they also face very high rates of very high borrowing costs at this point. And so you see the majority of the debt-distressed countries are also the countries that are facing HIV crisis today. And so it is not a situation where we're able to go to the capital markets to try to fill some of the solutions. Middle-income countries are figuring out some ways around it, but that is not the majority of the HIV programs that have been slashed so far. What we're looking at is low and lower middle-income countries that have huge challenges getting access to capital markets to begin with, that are not able to borrow in general. We also haven't seen a surge from the international financial institutions. And so we might have expected that IFIs like the World Bank and others might surge funding, but because of the models that are constructed there, they are responsive rather than proactive, and we're seeing struggles.
Thanks, Asia. This is Andy Seal from WHO, actually. First of all, appreciation to the panel. Fantastic interventions today and really important. I'm here on behalf of my colleague Meg Doherty, who is the director for global programs HIV, hepatitis and STIs. She would be very happy to speak to any journalist after today's session. So if colleagues online would like to get the details, we can find a way to get the details to you. And I've got some handouts for those in the room that also refer to some key resources that WHO has. First of all, a landing page where we're tracking all of the disruptions and keeping track of some of the opportunities as well as the data that are coming through. A number of media outlets covered a large survey that we did through April, where we had information back to us from 108 WHO country offices. So that covers all of health, not just HIV and TB. And it might be worth revisiting some of that if you're packaging features from today's session. And then finally, just a personal note, as well as being a WHO employee, I've also been living with HIV myself for more than 25 years and working in this on the response for a long time. And the one document that I have to say that we have on our website that I helped work on, which was absolutely heartbreaking, was entitled Guidance on Handling Interruptions in Antiretroviral Treatment Due to HIV Service Disruptions, Drug Shortages or Stockouts. I think many of us who've worked in public health for some time never imagined a day when we'd have to develop a document of that kind. Thank you.
Hi, I'm Andrew with DevX. I've been covering the impact of the cuts on countries in sub-Saharan Africa for the past 3 months, and I think that there's a lot of frustration on the ground about a lack of urgency from domestic governments to the crisis that's emerging. And I was curious to get your response now here at WHA, where I've also not heard a lot of immediate responses from any of the potential people who could step in and try to fill some of these funding gaps. I've heard talk today about potentially ring-fencing funding around sin taxes, but that's something that's going to happen in a number of years. It's nothing immediate. So I'm wondering, what could we potentially be looking for from actors who could step up now, try to replace some of these funds that have been cut by the United States?
So there's kind of a few pieces that I would say to your question, which I think is a really good one. As I was kind of starting to say, and I did pull up a couple of the stats here, one of the big challenges is that the level of cut that has come is dramatic. The speed at which it has come is unprecedented. In history, we have never seen the level of cuts and at this accelerated pace in which we literally 1 week had programs running and the next week they were told to shut down. That they were life-saving programs makes it even worse. And so governments are hugely struggling. They are caught in an impossible trap, which is, on the one hand, the most affected governments were completely unprepared for this. And perhaps they should have been more prepared, perhaps things should have moved more quickly. Many actors have been moving to try to increase funding, and there is an obligation of governments to move faster. And many African activists, for example, have been really calling for increased domestic resources, and Serge can speak to that, about achieving the Abuja Declaration, etc. But let's be very clear. No government in the world that's a low-income government can immediately find tens of millions of dollars on a week's notice in order to fund a program. That's not possible. Governments work in multi-year budget cycles. It's just simply impossible. It would violate legal expectations to be able to do so. Secondly, the best estimate here is that debt servicing now exceeds 50% of revenues in Angola, Kenya, Malawi, Rwanda, Uganda, and Zambia. 50% of government revenue is going to debt servicing. So there isn't the fiscal space for governments to be able to simply step up and find a way to solve this problem at this level. And I do think that there is a political bind here, because you have a situation where on the one hand, the most powerful government in the world, the richest government in the world, has just taken this action that has withdrawn medicine from people around the world and shown very clearly that any government that speaks out will be retaliated against. And let's be very clear that the current Trump administration has been retaliating against governments for speaking out against their actions in multiple different ways. One need only to look yesterday at President Ramaphosa's visit to the White House to see the ways in which that's happening. And so many low-income governments don't feel like they have the power to push back, and they don't have the fiscal space to be able to surge. And so it's literally a politically impossible situation that many governments find themselves in. And there's absolutely no need for it. There is certainly ways to transition programs and to think about a limitation and a withdrawal of funding over time. And in fact, in many countries, you've seen growth in revenue. Well over half of the HIV programs in low and middle income countries are paid by governments directly, and more can be done, but certainly not on the timeline that's given. Serge, do you want to talk about domestic spending?
Please. En fait, j'aimerais bien revenir sur la capacité des États à se mobiliser pour investir dans la santé. Ce matin, on a participé à un side event assez intéressant sur l'avenir du financement domestique en Afrique. Et il y a eu des prises de parole successives de différents ministres de la Santé et des différents ministres des Budgets qui, justement, essayaient de rassurer sur la capacité des États à se mobiliser. Il y a eu des exemples assez significatifs. Je pense notamment au Sénégal, qui a présenté l'initiative Compact, qui permettra au ministère de la Santé et à l'OMS, je crois, au niveau du pays, de réunir tous les fonds disponibles dans une sorte de common basket et de se rassurer que cet argent soit orienté et priorisé pour les besoins, justement, pour gérer la crise actuellement. On a eu également des exemples du Zimbabwe où le ministre de la Santé a indiqué qu'il y aura des taxes sur le tabac. Mais ce qui a beaucoup attiré mon attention, c'est la remarque de l'honorable Donald Kaburuka, l'ancien président du Fonds mondial, qui a dit, même si les pays africains honorent la déclaration d'Abuja, c'est-à-dire investissent 15% de budget de l'État sur la santé, ça sera la base minimum. Donc c'est le minimum qu'on puisse faire. Ce qui veut dire qu'aucun État ne pourra y aller seul. On a besoin de la solidarité internationale. Il faut bien sûr que les États investissent. Il faut bien sûr qu'ils respectent la déclaration d'Abuja. Il faut bien sûr qu'ils mettent en place des dispositifs, des taxes sur les sucreries, le fast-food et sur les cigarettes, par exemple, sur le tabac. Mais la solidarité internationale est vraiment importante parce que, comme il le disait, ce qu'on vit actuellement n'a pas eu de précédent. C'est une situation unique et la mobilisation doit venir vraiment dans les deux sens. Le sens de la solidarité internationale à travers un financement multilatéral et bilatéral et effectivement l'engagement des États à mettre en place des mécanismes pour avoir du financement domestique et pour respecter la déclaration d'Abuja.
I'd like to discuss how countries mobilize themselves to find funding. This morning I attended this side event on resource mobilization in Africa. It was attended by several African ministers. Its goal was to give assurance to the public on Africa's capacity in mobilizing resources. I remember that at this side event, a minister from Senegal presented a project called Compact. It's a project that allows the Ministry of Health in Senegal and WHO to put together funding in a common basket to address the current crises. And also Zimbabwe mentioned a very good example on their tobacco taxes. I also would like to quote the ex-president of the Global Fund. He said that African countries north of Abuja need to dedicate at least 15% to of their budget to address health issues. This is the very minimum. This means that no country in Africa can pull this off alone. Of course, African countries need to implement tobacco taxes, levy sugar taxes, but at the same time, we still need international solidarity, which is of paramount importance given the unprecedented crisis we're facing now. So yes, we still need bilateral funding and multilateral funding in order to fulfill our obligations under the Abuja Declaration.
Hi, Preeti from Geneva Health Files. I had a question about interruption to clinical trials. You didn't bring this up, but is this legally being challenged? And the second thing is, most of Trump's executive orders have been litigated except the one on WHO, and I was told that that it has been difficult for an American organization to demonstrate harm and issues of locus standi. Maybe has that changed, or?
Happy to get you some examples. There are kind of two ways to think, two funding sources through which clinical trials have been interrupted. USAID and CDC support small level, largely implementation level trials that are happening, and those have been disrupted across the world. But meanwhile, in addition to USAID cuts, we've also seen major cuts to the National Institutes of Health. And in South Africa, for example, we are watching some of the most important HIV science left, right, and center being halted. You've got major trials underway that have been shuttered. You've got all sorts of disruptions happening. So I don't have those off the top of my head, but I'm happy to get them to you because the answer is absolutely, right? And what you see is the centrality of the United States in this space, but also it's the richest country in the world, so of course it is central in the space. And so there's a really important kind of obligation that comes along with that that's been deeply disrupted. Your legal question is a really interesting one. The question of WHO withdrawal hinges on a couple of things. When the United States joined the World Health Organization, it did go through a joint resolution of Congress. And so many of the best US legal thinkers are very clear that the president can't unilaterally withdraw from the United States without congressional action. That does not seem to have stopped the Trump administration from doing many things. But secondarily, when they did join, that joint resolution required two things. One, it required notice, and two, it required payment of dues. So one of the questions that's actually raised right now is that the Trump administration has not paid the World Health Organization dues, even if you just look at the assessed contributions, and therefore it is actively illegal to withdraw from the World Health Organization. It's not kind of fuzzy, it's not questionable, it's not like unclear. One can simply look at the text of the joint resolution, which says the US can withdraw, but it must do so having paid its obligations. And it's interesting because when the World Health Organization was created, there wasn't a withdrawal provision included. And so the US actively inserted into its legislation a withdrawal plan because the US wanted to have one. And in so doing, it set its obligations. The question of who has standing is very interesting. And I won't say too much deeply, but there are several entities that could have standing. Universities have relationships with World Health Organization that are being disrupted. Local and state health officials depend on World Health Organization data, right? When COVID hit, when every epidemic hits, it is the World Health Organization that provides the data that the CDC depends on in order to be able to give its guidance to local and state health officials. That has absolutely been disrupted, and so that gives many governments, local and state governments, standing to be able to challenge. And then the third piece that's really important is that the World Health Organization provides information that is crucial for a number of decisions that get made. For example, the flu vaccine. The World Health Organization's role in bringing together scientists in order to share samples and to create the flu vaccine is central. If the United States is not part of that, they will not get the information that's required. It's not published. Some of it's just published, kind of broadly and publicly, but there's all sorts of other information there, which means that every doctor that has an interest in the United States in issuing and using the best flu vaccine has potential standing to be able to move forward. So it is true that there are numerous different folks who may well have standing, and I am aware that there are people who are considering how to stop it.
We need creative legal strategies in order to address what's an unprecedented attack on humanitarian assistance, on health assistance, and an attack on science, and the two go together. And I think one specific data point is that already the cost of cuts for HIV research alone is about $500 million, $450 million. That's just from the NIH. So leaving aside the USAID and CDC clinical implementation science, which is so crucial for all of us, no matter where we call home. But on that other side, the additional April and May chaos and bloodbath, that's $450 million for one disease alone. To say nothing of the attack on a unique global collaborative approach that the NIH had been funding, which was through US research teams that partnered with global research bodies through sub-grant awards all across the world, particularly when it comes to HIV in East and Southern Africa. There was an announcement by HHS leadership that type of grant implementation arrangement would be eliminated rapidly, which it's impossible to even understand how that will harm everyone's health, everyone's livelihoods, but also just the advancement of science. It's a death blow to collaborative research that seeks to put power where it should be, in the global south. And that's precisely the intent, unfortunately. So we have multiple fronts we have to fight on, multiple tools which are being deployed. I want to thank everyone for attending. I don't know if there's any final comment or question. Okay, we're at time. I'm so sorry we don't have a tea break or stale biscuits to share with anyone, but I'm sure you can go to a side event and find some snacks. We don't have money for that. But I so appreciate everyone's expertise and your commitment to writing about such an important issue. Thank you, and enjoy the rest of the World Health Assembly.